The views and opinions expressed on the Nurses Station are those of our hosts and guests,
not necessarily the views of Emory University,
the Nell Hodson Woodruff School of Nursing,
or Emory Healthcare. Enjoy the show.
All right. Hi, everyone. Welcome back to the Nurses Station. We're all happy to be here. This is our bi-weekly podcast where us nurses come together to talk about all things nursing. And today we have a really cool episode. I'm really excited about it because it's about nurse-led practices and innovation. And anytime it's about nurse-led, I get super excited because I think nurses are the best. So I want to thank everybody that has been emailing us all of these warm messages and posting on social media. This is going to be our final episode for fall. And remember to follow us on our social media and go to nursing.emory.edu to listen to our podcast. And also you can go to our LinkedIn group to get the show notes. And so how has everybody been doing? How have you been doing, Lexi?
You know, I'm okay. My daughter started back face-to-face school this week. So I'm a little bit, excited because I hate fourth grade. I found out. So I'm happy that I don't have to do that anymore, but then kind of just feeling that ambiguity about her being back in like a group setting. And also since she's back in school, I sent my son, he's 3, he's going back to daycare a few days a week. So I'm kind of in my mommy feelings today, but overall I'm doing okay.
Yeah. Nice.
Yeah.
What about you, Carolyn?
Yeah, we're kind of doing some questions, trying to figure out when we're going to see some extended family that we haven't seen all year. They fall into some high-risk groups. And so it's just been a question. Kids are still home. They're not necessarily being exposed, but we have some workplace exposures coming into the home. So it's just something we've been thinking about, and we're trying to pick the right time and figuring out all of the logistics that go around that.
Yeah. Tim Cunningham.
Roxana Chicas.
What's going on in your world?
I'm trying to start running again. I used to, like a decade ago, I ran like crazy, marathons, ultra marathons, and I realized COVID's been getting me down, and I've just gotten kind of lazy. So I've gone out running, and I'm feeling pretty good about that. Ran a half marathon a few days ago. But one thing that kind of freaks me out a little bit is that where I run, nobody's wearing masks. There are all these people huffing and puffing on these running trails working out, and no one has a mask. I keep a mask on when I run, and I got used to it here. And then I went to a different state for a day to just take a few days off. I guess it was multiple days off, and everybody was wearing masks. And I was like, Georgia, I don't think we're doing this quite well. So I got a little frustrated with that.
That's true, because when I was in Florida, everybody was wearing masks because the local governments there had mandated masks. And when I got back here to Georgia, it's like, where are the masks? I kind of feel naked without mine.
Mm-hmm. Yeah. So Tim, wait a minute, I had to back up. So you just picked up and ran a half marathon after not running you glazed right over that comment. Right. You just pick up and run a half marathon out of nowhere?
I don't always make the healthiest of choices in my life. I did. I had some free time. I pulled it off. I felt pretty good afterwards the next day, and actually still today I'm limping and I have weird ankle pain. But I did it, and
wow.
It felt pretty good.
That's amazing.
I mean, some people do couch to 5K. He just does a half marathon.
I might run a double marathon.
Right. Yeah, wow.
Well, I have a 4-year-old who goes to daycare, and apparently they've been learning about 6 feet. You have to stay 6 feet apart. And so we went to Costco, and we were in line waiting to pay, and the person behind us got a little too close to us, which I'm sure they didn't do it on purpose. Sometimes you kind of forget. But my daughter turns around, she's like, coronavirus, 6 feet. So embarrassing.
Does she like to run? Can she run with me and then scare off all the other non-masked people? I would love that.
It's so funny how toddlers or pre-K students, little kids, seem to have a better understanding of COVID-19 than some adults.
4-year-olds, my son will be 4 next month. They're pretty direct. Like last night we were sitting around and he likes to sing If You're Happy and You Know It, but this was like the 10th time he asked me to participate. So I wasn't, and he was like, if you're happy and you know it. Like, come on, Mom, trying to force me into it. But I'm like, I'm not happy because you're forcing me to sing If You're Happy and You Know It. So yeah, toddlers are interesting.
That's all the clown work that we do. We learn from toddlers. We watch how young kids respond to the world. And then as professional clowns, we learn how they do that. And then we do that as adults, which makes it kind of funny because like toddlers see the world in such an amazing way. And like, when do we lose that? And why do we lose that? It seems like they're having more fun than we are.
They are. Because if you ever saw the pictures in my phone, when he gets my phone, it's hilarious.
I love it when kids go into that phase where they have a lot of concrete thinking. So like, for example, I asked one of my kids once, so what was your test on today? And he looks at me like I'm weird. On paper?
Right?
Yeah.
To ask a more innovative question, right? They're innovators. Be more innovative. That's what I was telling you.
It's hard to keep that creativity going. Actually, there were some, now critical thinking is different than creativity, but you can kind of think about that along the same lines, right? And so for a long time, I don't know if it's still true, but tests of critical thinking actually go down after nursing school. Like we work it out of them because we're like, no, you got to learn these guidelines, these protocols. This is the best way to sort of move forward and prioritize and so forth. But yeah, it's that creativity can be really powerful for you as an adult, but we lose it.
So, but that creativity leads to innovation, and it doesn't seem like you've lost it, Carolyn.
Well, I never describe myself as creative, right? I think I'm just sort of maybe more of a problem solver, right? So I'm like, okay, this is clearly not working. There has to be something better that we can do. Let's try something different. So maybe that's creative, but that's kind of maybe, I don't know. I'm just like, let's fix this. I'm a fixer.
Well, you are the director of the Nurse-Led Patient Center Medical Home for People Living with Dementia Integrated Memory Care Clinic. And so that was a very innovative model that you all created. How did you come about with this?
True story.
You clearly wanted to fix something, right?
Well, I did, and it wasn't just me. I think that's really important. Mm-hmm. So I've been a primary care kind of person in geriatrics. Geriatrics can be lots of settings. I think people think of us in long-term care, but I've been a primary care person, and I had a colleague whose practice was in cognitive neurology, so doing a lot of diagnoses and then connecting people with research in the Alzheimer's disease and related dementia space. But what the two of us were hearing from family care partners was that this system wasn't working for them. And you could look at our data and look at the health-related outcomes of our patients and say, this system is not working. And a lot of people have made some good improvements in trying to do a better job, maybe connecting systems. So maybe connecting hospitals to subacute rehab for better transitions or transitions home, maybe bringing in aging service providers like home care, that kind of thing, and in Medicaid waiver programs. And I just kind of felt like we have all of these systems. We're trying to, pull them together better with like, sometimes it feels like duct tape and chewing gum to make it work better for people when maybe the whole system just doesn't work and we need to start with something new. And so that was really the basis for us creating this practice. These care partners said, look, my loved one who has dementia from Alzheimer's or from Lewy body or one of the other major types, and I'm bringing them to you in cognitive neurology, and you understand exactly what it is they're dealing with. But they have other health problems too, right? The average age is fairly advanced. So average age of our patients is 79. 79-year-olds have other chronic conditions, other acute conditions show up. So they were having trouble getting other places like primary care, or if they needed urgent care, to understand sometimes what the diagnosis was and why their person would behave differently, why they needed to check in differently. You can't just ask them the standard questions because they're not going to give you the answer that you need. I had done some work myself in the emergency department for people living with dementia when they came to the emergency department. And it turns out, they stay a lot longer. It's difficult to figure out exactly what's going on. A lot of your diagnosis is in the history. That means you need another source potentially to support what they're telling you. not in place of necessarily, to make a good diagnosis to get them to the right space. So this care partner said, look, we need care that understands our specific needs, that knows how to take care of those other conditions, whether it's acute or chronic, through the lens of dementia care. And dementia has this cluster of symptoms specifically related to the dementia syndrome called behavioral and psychological symptoms. And those symptoms can really drive everything for this person, including where they can live. And so to really be aggressive to evaluate those symptoms weren't even being assessed, and they're still not in most places. So evaluate those and then really aggressive about treating them to make their lives better and the people around them much better. So that's how we came up with the idea. We actually funded by two donors who were both family caregivers themselves, who identified that this was a need. I think that's why the model suits patients and families so well. It came from them.
Wow, organic. That's amazing. So Tim, Vice President of Practice and Innovation. What is innovation to you?
What is innovation to me? It's a really great question, because I struggle with that. And I struggle with that with my title, because I think about when often we say innovation, and LinkedIn has taught me that all these vendors from around the country, hey, you have innovation in your title, you want to buy our product and do this and that. And they're all technology. And they're all technology based, which is certainly a form of innovation. I think that we often are creating new technology to fix the problem that the last technology created. So I sometimes think we find ourselves in this technological spiral. So for me, innovation is much more along the lines of what Carolyn described. And I think about, have you all read the Book of Joy? Does that ring a bell? If you have a little downtime over the winter holidays, I highly, highly, highly recommend this book. It's interviews between Desmond Tutu and the Dalai Lama. And they're back and forth, joking with each other, laughing, and talking about joy, talking about compassion, talking about this world that we're living in right now. But there's a quotation in the book that when I think of innovation, I keep going back to that quotation. And it's something like this. There is an old Tibetan saying that wisdom is like water. It can always be found in the lowest places. Wisdom is like water. It can always be found in the lowest places. And how does that relate to Carolyn's model and my thoughts on innovation? Simply as that, Carolyn, you nailed it. It's the care partners. It's the family members who came forward and said, we need this because we love our family members and they're not getting the care they need. It wasn't some research scientist with 1 million letters behind their name. It wasn't some big fancy world-renowned physician. It wasn't some political leader driving this change. It was family members. And I think in healthcare, we sometimes treat family members as like the bottom of the barrel. And I think nurses are treated that way too. Let's think about nurse innovation and let's get rid of this hierarchy. And so for me, long answer to a really great question, innovation is first about seeking wisdom in places we don't normally look and building from that. And nurses, you've done it with your clinic, Carolyn. Nurses do it all the time.
All the time. Absolutely. I mean, I just think about all of the different ways nurses problem solve for things that are right in front of them and don't realize what an amazing opportunity that maybe they've created for themselves. So I've seen some comments on my social media feed about, PCA, or patient-controlled analgesia pumps, which is where you have a pain medication and the patient can press the button and have a dose released. And then it's timed out, though, because too much of that medication too soon is pretty dangerous. They tend to do things like stop breathing. So we want their pain controlled. So they have some control over that themselves, but it's also within some safe parameters. Really phenomenal invention in pain control. And so several nurses are saying things like, why couldn't, I've been thinking about this for patient call buttons. So, so for my patients who I'm sure when they do end up in the hospital, they don't remember that they've just pressed that button 60 seconds ago because memory is a problem. And so you get why they do it. But at the same time, when you're receiving a call light every 60 seconds, you're like, give me a minute. So, can we not time out the call buttons? And so I was sort of laughing at this, and another nurse was like, I thought of that years ago. Like, how many times, right? Have we been like, oh, I've come up with this really innovative thing, we sometimes, we do piece it together, maybe almost literally with chewing gum and duct tape. But, it's extra pieces of tape that we label things a certain way or color code things for ourselves because it's safer for the patient and it makes your work so much better.
Yeah. And for you, Lexi, what is innovation for midwives?
I mean, I think I concur with everything that everyone's saying. I think it's just having enough vision to kind of look at a situation and not decide how you're going to manage it just from your own professional opinion. You're like really scanning the landscape to see what's best for that situation. Just listening to what Carolyn and Tim are saying, it sounds like innovation, some of it's having an imagination and thinking about what could be. And I think sometimes we get so wrapped up in the services we're providing that, just like how we started this episode talking about our children, and where do we lose that? We have to ask ourselves that same question in nursing. Where do we lose that kind of energy and that imagination? So for me in midwifery, it's just been, thinking about what could be and kind of delving into the unknown and trying to bring that idea to light is how I look at innovation.
Yeah. I mean, what I got from Carolyn and Tim and you too, Lexi, is that innovation seems to be like listening to your patients, listening to the people around you. They're giving you like the ideas, what they need. And who would have thought that listening could be so innovative?
As I always say, the answers are always right in front of you. I always feel like the solutions that we seek are right there. You just have to dig. You have to be open enough, and your mind has to be open enough to see it. But it's often right in front of us, like a treasure. You just have to dig for it.
Yeah. Totally. One of my clown teachers said, Tim, it's always underneath something. When you lose things like your keys, I lose my keys at least 3 times a day, but they're literally always underneath something. So when I think of his words, I just start lifting things up, and there they are. One of my favorite innovations came from a clown, this guy named Michael Christensen, who was one of the founders of the Big Apple Circus. And in the mid 1980s, he was invited to go to a pediatric and ICU in intensive care unit in New York City. And he went in, he not everybody wanted him there, including the head physician. And he went in and was performing with children and making them laugh and things like that. And the head doc came up to him and he looked at him sternly and he said, "There is no place for clowns in an ICU." And Michael Christensen took his rubber chicken. I've got one behind me right there to honor Michael Christensen. He took his rubber chicken right back there on my bookshelf, right on there, grabbed his rubber chicken and he held it up and he looked at the doctor and he said, "The ICU, you're right, is no place for clowns. It's also no place for children." And he walked right into the next room, made the child laugh. And over time, this physician said, "Oh yeah, we see the value of clowns," because it's about connection. And so much of innovation is like, what can you do to like draw the attention away from maybe the crisis at hand to think about things differently? You never know when something might pop up.
What?
That? I forgot. I had this great surgical innovation. I have really bad allergies. I snore horribly. So one nostril is usually pretty open, but the other one I've had congestion. So I had a surgical squeaker implanted, and that helps me clear out when I'm having trouble. And it's great, but I forget. So if I'm in a fancy meeting and I want to dig a big goober out and squeaks, then everyone sees it.
I was so not ready for that. We were having this serious conversation and then you I was about to cry when you gave that speech about children in the ICU and then bam, a squeaky nose.
A squeaky nose can make you cry too. If it squeaks too much, like it brings tears. I mean, I'm not going to over squeak it. And that's why you notice I don't pick my nose frequently on this webcast, because it's like plucking nose hairs after a while.
Do you do this with your nurses? Do you have like meetings with them and then just roll out something funny?
I got to tell you, when I was practicing clinically, I carried magic tricks with me everywhere I went. I learned it from the Big Apple Circus clowns. I was working with a kiddo once, a 7-year-old who didn't want an IV started, and they were so afraid. We know the number one fear for kids in hospital settings is that of needles. So we were getting everything set up. We needed to start the IV. And right before I placed the needle, I looked at the child's arm right below where we were going to set the IV, and I pressed, and I was like, "Oh, did you know, have you ever had that checked out?" And the kid went from screaming and crying. The mom, who was in the room too, went from like total anxiety to be like, what is that? And in that moment of what is that, I popped the IV and the kid didn't even flinch. So like laughter, innovation, and distraction. So maybe that's a way to think about innovation. what are these distracting moments, and how are our brains thinking differently?
Have you ever done that, like in front of Sharon Pappas, like in a meeting with her?
So have I ever done that in front of my boss, Sharon Pappas? Not yet, but I think that's a really good challenge. So I will commit to, before season 2 starts of the Nurses Station, I will do that at least once, and I'll send you back a full report.
Please note her reaction. I want to be able to imagine what she looks like.
Please record it.
All right, I will. And if I don't come back for season 2, you will know that the Squeak episode did not go well, and I am currently looking for another job.
Now, what kind of contract do you have? Are we like good for a little while? Or?
So yeah, it's pretty open-ended.
Oh.
Yeah, I thought it was innovative when I signed it, but maybe not so much. Now we gotta laugh. We gotta laugh. If we take ourselves too seriously, we're not gonna innovate anything, because we're gonna be so focused with these blinders, we're not gonna pause. And I think laughter is a great way to pause, to feel, to think different. And in those moments, we think of new ideas.
And I think your point, along with Lexi's, is this notion of the collaboration often feeds innovation. So, for example, when I'm talking about us, the two of us, these advanced practice nurses, we're collaborating with family care partners. So they're saying, look, I'm going to present to you not just the problem. We all agreed on the problem, but here's something that we think would be effective. And then we had a certain perspective on how we thought we could actually structure this, and all the things that they don't necessarily need to be thinking about around organizations and departments and funding and billing and staffing and workflow and credentialing and so forth. That's sort of our piece that we bring to it. And so, when you're collaborative, you're working with other people, they've got their lens that they can sort of contribute, but you have to be open then to all forms, whether it's the clown in your ICU. And I know a lot of people get called clown, but literally the clown in the ICU or environmental services has been tremendously helpful. If you can imagine custodial care or nursing home care for older people, amazing innovations will come from that group as well. Maybe they don't necessarily have the nursing background. That's what you bring to the table to come up with new ways of doing things.
Yeah. So there are some nurses who have been very innovative and created things for us nurses to be more efficient at taking care of patients. Did y'all know that the crash cart was something that a nurse created?
Can you imagine somebody's coding and you're like all running, trying to get all different supplies from various places?
Yeah, that
would be crazy to think about not having all that in one cart.
Totally.
Yeah, and she did it in her basement. She created this crash cart in her basement back in 1968. Her name was Anita Dorr.
Right on. She had to have been an ICU nurse, because emergency nurses, even though we use crash carts all the time, we are so not that organized. So thanks to all you ICU nurses who have enough organizational thought to put a crash cart together that then we as emergency nurses can just destroy as we're digging for meds and supplies.
So go ahead, Lex.
I was going to say the idea of a crash cart for me is just horrible, because you don't want to see a crash cart in labor and delivery. So I'm glad they exist, but I really don't want to see it in my world. I just want to say that.
That's fair.
Yeah. So something else another nurse did. Her name was Terry Barton Salinas. She created color-coded IV lines. That just makes me think nurses are so organized.
Yeah.
Crash cart, color-coded IV lines. We're so efficient, and that's why we're awesome.
Yeah.
I agree.
Mm-hmm.
I mean, we're at the bedside, so the more you're with people, that's why it's always important. I think when you're trying to think about nurse-led practice innovation, like you have to include everyone, because everyone, especially the people that are doing the work, have the ideas. I'm just an advocate of just using everyone at the table. I know sometimes we have more of a top-down approach, like for instance, Carolyn, you might lead your clinic, so people might come to you all the time for ideas. But I think a good leader is going to really talk to the people that are the hands on the ground and really get their input. And Tim, I can imagine being over there at Emory Healthcare. That's what your nurses think of you. You come down and you ask them, what do you see as the future? How do you think we should tackle this problem? And I think if we have that kind of approach, that's how we can really make a difference.
Yeah, I try to take that approach, and it's tough because there's still a lot of hierarchy in medicine. And I think of other nurse innovators. Think of Dr. Tim Porter O'Grady, who's sort of one of the front runners since the 1980s on things called shared governance or professional governance, which, Lexi, to your point, is all about creating systems and policies within a hospital so that the voices of the bedside nurses can be elevated to the point where we are making policy decisions. And so when I meet with nurses and try to learn what's going on, I'm certainly met with excitement about we need to take this forward, but also, to be honest, a lot of mistrust. Because even though we've had shared governance around for a while, we don't always practice it the way we should. And our bedside nurses, their voices are not always elevated the way they should be. So that's certainly a part of my job, is how do we improve that elevation? And how do we let leaders of health systems recognize and know and have a little bit of vulnerability to really authentically hear the voices of our nurses to help make that change? Because like a lot of systems, healthcare is very top heavy and top down, and not so progressive that way.
That's true.
Yeah, I think one of the reasons I see a fair number of nurses embracing some of the lean operating system that many health systems are starting to use is this notion of ideas bubbling up from frontline, even when an idea comes out in the leadership team, that you go to the Gemba, you go to the place where the work happens. And that's really around sort of more immediate problem solving. But I do agree with you. Nurses come up with these brilliant ideas. I think they may not even realize themselves, like, this is just the way that I get through my shift. This is the way that I do patient care, and it makes my life better. And I think it's better for my patients. And they may or may not raise that or elevate that up to a leadership level to say, this seems like something we should spread. And if they do, it depends a lot on how receptive leadership is to that. But we also don't really think, I think, in terms of nursing education, at least formal degree programs, about taking nurse ideas and letting them think about not just, if this solves a problem for you and your patients, what would this look like if you did this as more of a business? If you actually produced this, if you actually taught others to do the things the way that you do them, because you've demonstrated that you really are expert at this and you could do this as an entrepreneur.
Yeah. Carolyn, I just got breaking news.
Oh, no.
Apparently, we've had several acronyms thrown around.
This was nurse-led. It was a nurse-led innovation. Let me guess who it was.
Okay.
Okay, I'll stay out of it then. Go ahead.
No, we all know.
I didn't drop any acronyms just now. I've been completely acronym free.
No, Mr. Tim Cunningham.
What did I say? What did I say?
I'm pretty sure you said Roxana. I don't even know because I didn't get the memo. Tell him. I know it was him.
Right. I believe you said Ivy. Oh, that was me.
Oh,
what was it that you said?
No.
I think he said ICU.
ICU.
I think Carolyn said ICU also.
We've all said ICU.
We've all done it.
Yeah.
But
no, that's all right.
We've already defined ICU like in previous
several
episodes.
times.
So
That's good.
I've already paid for ICU. I bought that round.
Yeah, and I'm apparently like buying for the whole bar when we even do it. So, if you want to add one more to me, what's one more? I'll take it.
you're already in the double digits, so.
And proud of it.
He's an acronym teenager.
That should be an innovation. Holy cow. Someone should create like an acronym alphabet that is standard across the US for nursing. Because even from health system to health system, we've got different acronyms.
Yeah.
Yeah.
That would be.
Let's do it, VP of Vice President of Practice and Innovation.
Yeah.
Yeah.
I'm gonna get on that. I'm gonna talk to my people.
And we can do a TikTok about it.
Ooh.
Ooh.
Did you enjoy doing TikTok, Tim?
TikTok
video?
was a blast. It's the best thing since sliced bread. And I'm grateful to have a support team here that's helped with the TikTok, because Tim trying to do his own TikTok, you should have seen that. Like, that was not so pleasant for me, but probably really funny to watch. I hope y'all are checking out our TikToks.
Yeah, we're
You're
about
amazing.
to add to those TikTok videos.
Mm-hmm.
Sure are.
Yeah.
We're going to be innovative with them too.
I'm thinking about, what about all this nurse research that's going on? Like, Roxana, I mean, something that I struggled with when I was teaching in an academic setting was because I get really impatient and I just want to get things done. And I think research is challenging because it's like you're doing essential, important work, but we might not see the outcomes for like months or a year or so. Yeah, right? I mean, so what does innovation look like from a research perspective? And what keeps you going, knowing that 5 years from now, we're going to see positive change, but you have to be so rigorous to get there?
So I recently submitted an F-32 for a postdoctoral fellowship.
What is that?
A postdoctoral fellowship. I don't know why they call it 32.
Grant mechanism.
Because it comes after 31, which is the pre-doctoral fellowship.
Well, yeah, of course. But
I'm just answering the question.
The test was on paper, Roxana.
Yeah.
And why is it F? It's like, I just graduated from my doctoral program. Oh, F. I got to get
fellowship.
Oh, it's fellowship.
Fellowship.
Ah.
Yeah.
But so I didn't have like I thought I didn't have a question, but in talking with my advisor, the dean, Linda Bacali, I was asking her a bunch of questions about A1C and glucose and farm workers. And she just said, that's a really good question, Roxana. You should, that should be your F-32. And so I'm looking to see how I want to explore how perhaps fructose is, maybe there's some kind of metabolism anomaly happening with farm workers, and maybe that is leading to them having acute kidney injury or chronic kidney disease, which is something that has been studied in mice, but not in humans. And so when I tell other people who look into heat-related illness and acute kidney injury, they think it's so innovative, but I didn't realize it was until I was told. So I think that we're very innovative all the time, but just don't see it. So, and how do you, when you have an idea, like Carolyn, this idea, or how do you make it come to life?
Yeah, right. So I think it depends on whether you're thinking about sort of a entrepreneurial product or service, and there is sort of a process for following for like business planning, for example. So, and I was thinking that is sort of a similar space that research occupies to that initial idea, which is what is the need that's not currently being addressed? What is the information that is not currently known? What's the gap that exists? And then what is your idea for meeting that on the business space, and what's within that scope and outside that scope? What's important? What are the goals? What are you trying to do with it? So if you're sort of moving forward with this product that you want to make more of or test more, or a service that you want to offer, you would follow that kind of a plan. I think around this model of care, it's a weird space. You can really, I know a number of nurses who are doing new models of care have come from a home base of academic nursing, that it tends to be a space that can incubate and support building out, like, okay, let's test this. Let's put some resources around this. And we are privileged to have resources, whether that's philanthropy or, donors or grant funding from a foundation or from other sources to start it. And then you have some support to test it and rigorously evaluate whether or not it works. And then they go from there. And there are a number of great examples around models of care. Of course, all of my examples are in the older adult space, but they are quite the consumer of healthcare. So that I think makes sense. And the healthcare that we've created, in my opinion, works really great for 40-year-olds, but not so great for 80-year-olds. So then you get lots of gaps. And so that's what I've seen.
Nice. I just got another breaking news that apparently I just used another acronym, A1C.
You're stacking them up today, Roxana. Like, what's up with that?
Well, you need to just explain what it is. You just throw it out there, assuming.
It's hemoglobin, A1C, glycolated hemoglobin, just to measure your glucose levels the past 3 months.
See, that's all you have to say.
Huh. What if my blood squeaks when I measure it?
Oh my God, could you imagine being the nurse and you're trying to get blood out of Tim and then he starts squeaking?
I did once.
Get him out of here.
I did once have a fart challenge with a patient. They were really nervous about getting an IV started. And I was like, how about, I tell you what, as soon as you feel the pain of the needle, you fart as loud as you can. And I'm going to fart as loud as I can at the same time. And we both farted and the IV was set.
This is a
I don't think
pediatric patient.
I don't advocate for that because that could go really wrong.
They were wearing a diaper. It's fine.
Although pregnant women do that a lot. We probably should do that.
So you can squeak and fart on command?
Yeah.
Nice.
I can't sneeze on command. If I were to fart, sneeze, and squeak at the same time, my brain would explode.
That's just doing way too much entirely.
Well, I think about one of my emergency nurse mentors, this guy named Bob, and he would always, I think I mentioned this on an episode before, he would always say, Cunningham, improvise and overcome. Like when you don't have the supplies you need, improvise and overcome. And I think about innovation for the knowledge that we carry as nurses with our basic undergraduate nursing training, one, the platform. And then we take that forward into our specialties, whether they're research, whether it's nurse practitioner, whether it's administration or leadership, it still is all based on the pathophysiology that we've learned, the chemistry that we've learned, the biology, the lifespan learning. In 2015, early 2015, I was working in Sierra Leone in an Ebola treatment unit. I was a frontline provider caring for people with Ebola. And we had limited supplies. We had like 9 medications in our entire pharmacy. PPE, we never had enough. It was the wrong kind of PPE. Like we were struggling a lot. And I remember we had one kiddo who tested positive for Ebola, got really sick, but then started getting better. So we thought she was going to survive. And but then a few days into her sort of improvement of symptoms, we thought we were going to be able to discharge her. She stopped peeing. And we couldn't figure out why she wasn't peeing. And we were really worried that there was another disease process going on. And we're like, she's going to die of something else because we can't get her the care she needs. And one of our nurses was like, she probably doesn't have enough protein. She's got this thing called protein anemia. So we thought, well, great, but we don't have albumin, which is the medication you give to help support someone's protein. And then another nurse was like, we don't need that. We have eggs. There are chickens running around everywhere. So we went to one of the neighbors to the ETU. We bought a ton of eggs from them, hard boiled them. Next day, gave her 2 hard boiled eggs to eat. One, she got excited about food for the first time she was in the Ebola treatment unit, and literally within about 5 hours started peeing again. And so like that innovation coming from a nurse who learned this stuff in pathophys like decades ago, because this nurse was a little bit older than all of us, like saved lives. And also was like, we didn't need high technology. We needed to know the neighbor that had chickens.
She was a seasoned nurse.
She was a seasoned nurse. Yeah. Right.
You know, that's funny you say that, Tim, because you had made the comment earlier that innovation gets equated with technology so often. And I think there are people, especially in community settings, who would say technology has been really hard, stifling innovation, right? So, you know, when you're in that ICU, which I think we all agree, we know what that is now, you know, you get really comfortable. You just sort of look up at the monitor. You can see what the rhythm is. You can kind of get an idea around oxygen saturation. I was doing post-surgical care. So I looked down at the Foley, which had the internal temp on it. I could look at urine out. I mean, it's all kind of right there. And I could just like, you know, get something quickly from the pharmacy if I needed it. I wasn't having to come up with, okay, let's get back to why that works and what are my other ways I can accomplish the same goal, or having to do an assessment with your hands and touch people and, you know, and use your actual physical exam skills again. So it's just kind of funny. I mean, that's such an innovative approach, right? She's solving a problem. She's getting at the root of it, using her expertise to make that patient have a significant, like a huge outcome improvement. That's not just like life or death kind of distinguishing opportunity. So it's just, you know, it's just kind of funny to me, like that's innovation and not technology, which we somehow have made those two equate.
Yeah.
I have a question. So Carolyn, how do we teach our students this? Like, how do we prepare them to be innovators and maybe hopefully entrepreneurs if it leads to that?
I think we've certainly focused on educating nurses as problem solvers, right? So, and we are, even though some of the standardized measures around critical thinking don't look like they fare very well with nursing education, you know, the idea of getting at, we've talked about this forever, why are you doing something? Why is this the most important first step? Why is this the priority? Is around kind of building that base so that you then can think on your feet and to come up with those. Now, from the business perspective, though, we have not made that next step. So here are ways to solve a problem, and we'll certainly see it role modeled and in practice, but getting it to a larger scale and identifying ourselves as not just solving the problem for this one person in front of me, but for the system or for a much larger group of people. That we're missing that. That's definitely a gap.
Yeah. So there is one nurse that I think is awesome because she created, her name was Elis Sorsen, and she came up with the ostomy bag. And I have a thing about pieces.
How
So
do we always manage to get back to poop? Y'all are just, you can't help yourselves. Like, no matter what we talk about, somehow we circle back around to a body fluid or poop.
Tim did it
What
first.
is it?
He's walking
Are you
the
guys
fine line.
obsessed?
Yes, we are. And ostomy bags, they are amazing. When I
No, we're not going to do this.
Before I even wanted to be a nurse, before I knew I was going to be a nurse, I graduated undergrad, majored in English, wanted to be an actor, blah, blah, blah. I lived in a little corner of a dorm. Yes, I was a senior living in a dorm. I was that guy. But we called it the ostomy bag. And we don't know where the name came from. And so for like our last day of classes, you go around and toast the different buildings where you had classes. We got a bunch of ostomy bags and filled them with like Kool-Aid and vodka or something. And we drank out of the ostomy bags everywhere around campus. They do not leak. And I think for folks
Really
like
now?
Roxana who do not like poop, for folks that want to have a nice like pouch or flask that's not going to leak whatever you've got, like ostomy bags are amazing.
Is this how y'all feel when I talk about maternity stuff? Like, you're just like, how do you?
Maybe a little. So listen, this is a funny thing. So, or an interesting thing. So speaking of nurses and patients sort of collaborating for some of this innovation. So, the space around intrastomal nursing was not a nursing specialty. So patients had sort of among themselves created this advocacy, kind of a support network about how to manage their stomas, apply different devices, some of the sealant, all of those products. And then nurses later got involved. And then essentially, as I understand it, that patient network honestly bestowed nursing, like you guys can take this forward to the next step to make this part of. So ostomy nursing was not a specialty. Basically, patients honored us with that specialty to then have as our focus.
I didn't know that. And to add to that, our wound ostomy incontinence nurses here at Emory are unstoppable. Just a shout out to them because they have gobs of supplies, gobs of different ways to attach an ostomy bag to make sure that a patient's skin stays intact and safe and healthy, but every person is different. And so these nurses are innovating on the spot every single day. Where is the wound placed? How long is in the healing line? Like, I tip my hat to all of our wound ostomy incontinence nurses. True innovation.
Yeah, they're incredible. And I don't think most people realize that Emory has one of just 5 wound ostomy continence nursing education programs in the country.
Oh, wow.
Wow, that's amazing.
Huge.
Yeah.
Yeah.
Well, it looks like we are heading to that time where we're about to end. And so since this is our final episode for the fall, I would like to know from each one of you, what is a piece of advice that you would like to give nursing students or nurses as they go into nursing or are in nursing and are feeling kind of burned out? Lexi?
Burnout, as you know, we've talked about this season a little bit, is sometimes a part of it. But if you can just always remember why you decided to go into the profession and keep that in your heart space, I think that you can push through and do anything. And the reward of being able to be a nurse, to be able to be at people's bedside when they need you the most, I think it's just one of the best things you could ever do. I mean, I don't have any regrets about becoming a nurse. And so even when as our profession has shown throughout the COVID and a lot of different things, when it gets hard, we just dig down and we do it. And I think that's the beauty of being a nurse. So as you're a student, just hang in there and know that it's worth it.
Tim?
I'm thinking about the interview that we had in a past episode with Angelina Ruffin, and she wrapped up that interview talking about the importance of self-care. And I can't stress that anymore. As you progress in your nursing education, keep practicing that self-care. What is it for you? Short amounts of time, long amounts of time, keep caring for yourself. So you got a toolkit so that when you face the profound stressors that we face as nurses, you'll have some tools to practice that, to keep yourself going, to maintain resilience in a healthcare setting. So 1, self-care, and 2, have a plan, set that plan, set goals. And then part 2 of that plan and your goals, I'd recommend be for those to all change. And know that in the nursing profession, you can change directions multiple times. This is sort of my 3rd career within nursing with what I'm currently doing. And I hope it's not my last. I love what I'm doing, but all the more I love all the potential in nursing. So be ready for change, embrace change, and love yourself as you're moving forward.
Dr. Carolyn Clevenger.
Yep. So I'm thinking about the end of the year and how at the beginning of the new year, it's that fresh start time and looking forward and being hopeful and future facing. And I think that's so exciting. And I think setting goals like Tim was talking about, I would also ask that you take the moment to pause and reflect back. Even if it has been an especially challenging year, there's so much value in doing that, in considering both the high points and the low points, and what pieces of those you want to take forward and which things you wish to leave behind, but the lessons that you've gained from that. So whether you're someone who likes to journal and you want to write that with prompts, there's a lot of value in that. There's a lot of value in saying it out loud. Sometimes saying what you think helps you learn what you know. But if you do that, record it for yourself. There's just a ton of power in spending that time in reflection. I think it's probably great if we reflect on a very regular basis, but at a minimum, do it as you wrap up this year before you go into the next.
Yeah. What I would say is, I think all nurses, both nursing students, is to enjoy the ride and ride that comet to wherever it takes you, and smile and laugh and listen to your patients, listen to your advisors and your colleagues, and be fierce. The world needs nurses, and we need more nurse leaders. And I want to take this opportunity to thank everybody who has connected with us, who has allowed us to come into their homes or while they're maybe exercising, listening to us. It's been a great honor to be able to be here with amazing colleagues, and also to share our stories with others. So
I agree. I can't believe we're at the last episode. I mean, it's been such a good time. We've talked about so many things. I mean, it's been wonderful. So, yeah.
I want to grow up to be like you all. Like, yeah, we've been recording these in Zoom separate, and when do we actually get together in person? And
I know.
Y'all want to take a joyride?
Yeah.
Yeah, something. It'd be nice when we can get in the same space. I imagine having these conversations face to face, it'll feel much more natural for us because that's who we are as nurses, right? We're with people. So I'm curious to see how these conversations would go face to face. Maybe one day we'll get to do that.
As long as we're 6 feet apart.
6 feet.
Yes.
Roxanne, you can bring your baby.
Yes.
Help us keep us in line.
Yeah.
And then we can sing if you're happy and you know it.
Yeah.
Yeah.
Alrighty then. Thanks everyone.
Thank you all.
Bye-bye.
Thank you. Hope to see you soon.
Bye.